Thank you so much, dear Chair Lady. It's my honor always to be with you. And of course, I'd like to thank all the members of the Egyptian Society for Hematology and Research, especially دكتور عزة كامل. الحقيقة كل سنة بتعزمني ومش راضيين تحرموا رغم ان المحاضرات ما بتبقاش قوي يعني. طيب. Well, ladies and gentlemen, I'd like to start with the title. It's the non-chemo approach to cure blood cancer. Maybe it's the first time to say cure in the field of blood cancer, but actually this is a fact. So what I can say is dreams are coming true, because nobody can imagine that patients, for example, with lymphoma or leukemia, now the cure rate is on the rise. So this is going to be the theme for the presentation. First of all, I'd like to welcome everybody to the world of blood cancer, just a brief introduction. Then the robust concept of the non-chemo policy to cure blood cancer. Thirdly, there are really amazing achievements, as I'm going to show you right now. And final, two crucial issues which had been recently introduced in the field of hematologic malignancies. Well, always our dreams are to achieve the best, but dreams can be sweet dreams, exactly like this. Definitely sweet dreams, and the sweetest of all. So, of course, not all of them are sweet, so the next ones will be some nightmares, and of course, as we all know, رغم ان هو ناس طيبين جدا والله, لكن anyway, that's it. Let's start science now. Very impressive cancer facts are going all over the world right now. First of all, these are the American statistics as the year of 2017. So blood cancer, about 10% of all cancers are blood cancers every year. And the percentage of overall survival for blood cancers, really, these are impressive figures. 63%. 5 years of overall survival for acute and chronic leukemia when combined. 70% for non-Hodgkin lymphoma and 86% for Hodgkin lymphoma. And to your imagination, well, every 3 minutes in the United States, actually one person is diagnosed with a blood cancer, and every 9 minutes, one person dies from a blood cancer. These are the 2019 statistics, again, the American figures. Well, these are, again, the 5 years overall survival, and you can see that the most successful and speedy successful, in fact, are, as you can see, leukemia, non-Hodgkin, and prostate. And unfortunately, still the worst ever are bronchogenic carcinoma and pancreatic carcinoma. These are the Canadian figures, and actually it is very impressive, and I was really surprised when I saw these figures. In also 2019, they have stated, and I'm quoting, some of the biggest increases in survival had been for blood-related cancers. Now, what I'm going to show you is the percentage of change, not the overall survival. It is the percentage of change which happened for all cancers. So we see that the highest percentage of change, or let's say percentage of success among all cancers, you will find ALL, CML, non-Hodgkin, multiple myeloma, CLL, and these are really progressing in the rate of success. While the percentage is not that high in AML, and you'll be surprised in Hodgkin lymphoma, although Hodgkin lymphoma is very treatable. That's why the initial success rates in Hodgkin lymphoma is high. So just a matter of 5% or 4.8% for further success in the treatment of Hodgkin disease. Now a question for you, ladies and gentlemen. Do you like chemo? في أحد في القاعة بيحب الكيمو؟ I think this should be the answer, because of course nobody likes chemo, and this is why I'm presenting this presentation. Now, the robust concept of non-chemo approach. In fact, whether we like it or not, it's all about cytogenetics and molecular genetics. Without these new approaches, nobody can say that the blood cancer will be treated. For example, the CML, because back in 2001, it was the first time to state the phrase targeted therapy. So with the introduction of imatinib, as being said at that time, this is the miraculous pill or the magic pill, as we all know that it is the first tyrosine kinase inhibitor, actually rendering CML no more that catastrophic disease, especially the transformation. So to your imagination, this is what happened for CML over a period of 7 years. So if this is the non-cancer population, so we take some population, and this is the non-cancer population, imagine that these are the patients with CML who received TKIs, tyrosine kinase inhibitors, so the same survivor. So when I'm in a chronic phase receiving TKI, I'm living as good as a normal person. While this lowest CML survival is without, or let's say, patients who did not receive TKI, and the difference is quite huge. And hence the concept now of treatment-free remission in chronic myeloid leukemia. So it had been stated that for those patients who maintain major complete molecular response, who maintain this response for 2 to 3 years, they can stop the TKI and live without treatment. And then for more than six years now, 50% of these patients who stopped the TKI are in major complete response. So, and by the way, the other 50%, when they reinitiate the TKI, they enter into the same major complete response. So if these beautiful results are maintained, are we going to talk about functional cure? Nobody knows. Then we come to the amazing achievements. Maybe you will say that, yes, maybe in 1 or 2 or 3 diseases. Actually, no. It's in multiple myeloma, CLL, AML, and the nightmare of ALL. Among others, of course, such as Hodgkin lymphoma, the very aggressive non-Hodgkin lymphoma, and hairy cell leukemia. So multiple myeloma used to be one of the worst ever failures in treatment of the patients. And of course, nowadays, when you say the word worst failure, of course, there is nothing except this person. Okay, and of course, bye, see you next century. Okay, but unfortunately, we lost, or let's say we got rid of that person, but unfortunately, we are going to lose this person. Okay. مراتي مضايقة جدا بالصورة دي. So if we go for the follow-up of multiple myeloma through the years, you will find that the 5-year survival is booming up on the curve, and more than 13 therapies had been approved by the FDA for the treatment of multiple myeloma, and this is 45% 5 years disease-free survival. Is that all? No. Please look at the 2019 figures of the National Cancer Institute. So they said that in 2019, more than 32,000 patients will be newly diagnosed, among which 40% will die. Is this bad? Of course not, because the eventual 5 years overall survival now is more than 52%. Who would have believed that patients with multiple myeloma can live for 5 years in this percentage? And the good news is now death is falling by about 0.5% each year. Why is that? Because as we know, everybody, that the induction of remission by myeloma, the vast majority of protocols now are non-chemo containing protocols. The vast majority. because of the introduction of the targeted therapies, followed by autologous transplantation in order to deepen the response, and finally the maintenance therapy of multiple myeloma, which is essentially non-chemo. So in the maintenance therapy of multiple myeloma, there is no single chemo maintenance. So the concept is, with maintenance of such non-chemo, we are trying to convert multiple myeloma into a chronic disease. So believe it or not, from 1950 to 2015, this huge number of drugs had been invented. So initially, we started with chemo and steroids, then the autologous transplant, then the discovery of the first generation proteasome inhibitors such as bortezomib, and this had been the first revolutionary step in the treatment of multiple myeloma. Then the first and second IMiD, generation IMiD, which is the immunomodulator, followed by the third generation of IMiD, such as the pomalidomide, and eventually the monoclonal antibodies attacking the myeloma cell. And second generation proteasome inhibitors. In fact, the monoclonal, which is daratumumab, is the first actually drug, but of course we have lots of drugs again, did revolutionize the treatment of multiple myeloma, because with the use of these monoclonal antibodies, we started to talk about MRD negativity in multiple myeloma. So the word of wisdom after all of these drugs is that when you fight a killing monster, please use your hardest weapon, not only just a hard one. Okay? Anyway, so if this is the myeloma cell, ladies and gentlemen, we have so many targets in order to kill this myeloma cell by proteasome inhibitors, IMiDs or immunomodulators, and finally the monoclonal antibodies. So when you combine different drugs, definitely with different mechanisms of action, there is more chance to eradicate the myeloma cell. Let's, for example, I just want to talk that it is a matter of cytogenetics and molecular genetics. So we all know that the deletion 17 is the worst ever in CLL, and the best is deletion 13. So these cytogenetics will definitely impact your treatment and will impact your survival. Furthermore, with the introduction of the so-called immunoglobulin gene mutation or rearrangement, definitely we are getting closer to all of the bad risk factors which should be treated aggressively in order to achieve a remission. So believe it or not, this is the current policy of treating patients with CLL. So you diagnose CLL and you see if this is the patient is symptomatic or asymptomatic, or let's say indicated or not indicated for therapy. Once the patient is indicated for therapy, the immediate step is you have to diagnose if this patient is deletion 17 or not. Because with deletion 17, you will go, for example, into ibrutinib or the anti-deletion 17 drugs. While if the patient is non-deletion 17, the next step, you have to determine if this is an immunoglobulin gene unmutated or not, because accordingly you will treat. So whether we like it or not, it's a matter of cytogenetics and molecular genetics. So for each step, there is a different approach. And when we discovered the B-cell signaling, these are some of the newer agents. So if we have the BCR or the B-cell receptor, now we know very well that activation of the BCR with the signaling, you will go through a huge steps in order to end into oncogenesis. So the newer anti-CD20 is obinutuzumab, while the original was rituximab, and I don't know if there is a big amount of data favoring obinutuzumab in a clinically significant fashion or statistically significant fashion regarding overall survival in CLL. Then the idelalisib, which acts, of course, on the P3IK receptor, and the ibrutinib, which was a revolutionary drug in the treatment of deletion 17 because it acts on the BCR, the Bruton tyrosine kinase. And finally, the anti-BCL2, which is the pro-apoptotic, or let's say the apoptotic family, which determines which cell to die and which cell to live. So the venetoclax came as a rising star, not only in CLL, but even in AML, acute myeloid leukemia. So let's see now what is the overall result of CLL actually in your routine practice. So what did we achieve? And as you can see, over this huge number of years, that's what we, with a so huge number of patients, more than 700 patients, actually, as you can see, you can see that the overall survival is not reached, which means that there is a plateau without a decrease in overall survival in a statistically significant fashion, and this is really a very good achievement in CLL. Similarly, in the aggressive diffuse large B-cell lymphoma, we all knew now that according to the WHO, there are two subtypes of the CCO or the CCO, or the cell of origin. Actually, we know that we have two origins, the GCB and the ABC, and of course the ABC is much worse. More deeply, going through more cytogenetic and molecular analysis, we all know now that there are gene mutations, translocations, and rearrangements creating more aggressive lymphoma. So we started to realize that there is something called MYC mutation, BCL2, and BCL6, with a good number of percentage existing in diffuse large B lymphoma. Hence, the recently discovered very aggressive lymphoma, which are unfortunately treatment resistant, such as the double hit lymphoma, MYC and BCL2. This is worst of the worst. Double expressive, there is no rearrangement, but there is overexpression of both of them. And the triple hit, the three of them are existing in both in the same cell. And accordingly, you now should tailor your treatment according to each cell of origin. So we entered into the cell, we knew the mechanism of pathogenesis, and we are targeting this with the specific drug which should go and attack the pathogenetic steps. The final crucial issues I'd like to discuss with you, ladies and gentlemen, of course, I cannot go home without discussing minimal residual disease. Just briefly, of course, and the CAR T cells. Minimal residual disease, in my opinion, is a miracle in the field of managing patients with blood cancer. Even my colleagues دايما بيقولوا لي عمر MRD. Really, really, in my opinion, fascinating. However, so minimal, it does not say that the concept is minimal. Of course not, okay? Because sometimes minimal struggles. So أعتقد كلنا فاكرين المسرحية دي ما تقدرش. This is minimal, but really, really can struggle. So, of course, needless to say, MRD is the presence or detection of those residual malignant cells after treatment beyond the capability of our routine lab techniques, uniquely used in blood cancer. That's why, ladies and gentlemen, I'm saying that definitely the progress in the treatment of blood cancer is far much better than the solid tumors. For example, let's take multiple myeloma and the MRD concept. Of course, this is the tip of the iceberg, and with this extensive number of myeloma cells, 10 to the power of 12, while below is the actual disease burden. When I say hematologic complete response or complete remission, you are just here, not even in the middle of the iceberg. But with the use of MRD, so let's take, for example, by the flow cytometry, let's say, which can detect up to 10 to the power of -5. You are just here. Then with the NGS, you go deeper. Then, of course, if we went deeper, so are we talking about a cure? Let's hope But what I can say clearly that we now can detect 1 per 100,000 or per million in order to say that this is an MRD negative. So MRD negative, almost no more myeloma cells. So with MRD, definitely, you can evaluate the current tumor burden, what's the efficacy of your treatment, and we can definitely predict relapse, whether we like it or not. But the main challenge, are we going to change our treatment according to MRD? Up till this moment, this is the main challenge in the world of MRD. Believe me, within the coming few years, inshallah, bismillah, we will base our treatment according to MRD. Of course, sensitivity matters, whether I'm talking about the PCR or the multi-parameter flow cytometry or the NGS, the next generation sequencing. And this is one of the most famous trials in the field of MRD detection in multiple myeloma, simply because it had been conducted on 700 patients. And what was the final evaluation after treatment? Huge difference between MRD negative and MRD positive patients, with this extensively significant p-value at 5 years. I'm not talking about few months, I'm talking about 5 years. Now, apart from multiple myeloma, 2 final nightmares are becoming now to be converted into sweet dreams, but we are still in the beginning, So if I am talking, for example, ladies and gentlemen, about AML or ALL, is there any improvement? The answer is yes. In 2020, this is actually the novel risk stratification for AML patients receiving allogeneic hematopoietic transplantation, and this was published in the Biology for Blood and Marrow Transplantation journal in 2020. So I'm sorry for the small texture, بس الحقيقة ما قدرتش أكبر جدول أكتر من كده. But anyway, when we want to put risk stratification, definitely, first of all, I have to talk about secondary AML or very high risk cytogenetics. For each of these, you will gain 1 bad point. Then, according to MRD. So MRD now is entering so strongly in the new risk stratification. So believe it or not, ladies and gentlemen, if you are, of course, CR with negative MRD, no single bad point. But if you are positive MRD or unknown MRD, you will gain 2 bad points. And eventually, if you are, of course, active disease, you will have 4 bad points. So accordingly, ladies and gentlemen, this is the net stratification score. So low, you just 0 to 2, intermediate, high, and very high. So what are we talking about? The introduction of MRD as an independent risk factor for those patients who will have allogeneic transplantation. The other more established MRD-based sweet dream will be ALL دالية mobile okay, is ALL. Adult ALL is one of the worst of the worst of the worst. Adult ALL. Okay? And this is even in 2019 as per the NCCN guidelines. Very simply, you give the patient a treatment and the patient enters into a complete remission. Thank you. Is this the end of the story? No. You have to evaluate MRD. Accordingly, you will consider your treatment. So if you are MRD positive, which is not that good, so go for treatment, non-transplant treatment, or consider transplantation. Of course, they are writing blinatumomab. Of course, it's a miracle, the blinatumomab. You can achieve like 80% of complete remission, but unfortunately, extremely expensive. Or consider transplantation. If you are MRD negative, very good. Continue your chemotherapy or whatsoever, or consider transplantation. Of course, if you are MRD unavailable, so you don't know what's your MRD status, so please go to transplantation. So look at the importance of MRD even in the nightmare of adult ALL. The final crucial issue is the CAR T cell. طبعا anybody can talk for like 3 years about CAR T cells, but I have only 2 last slides. The chimeric antigen receptor, or the CAR T cells, it's a form of genetic engineering. So like 10 years ago, when you say, yes, the medicine will talk about genetic engineering, بالسلامة, nobody can dream of this dream, but it did happen. And this had been approved by the FDA in 2017, initially for very aggressive ALL and non-Hodgkin lymphoma. And يعني والله, I can say it proudly, it's very promising in hematologic malignancies, while it is quite unsatisfactory for solid tumors. In its simplest concept, and this is my last slide. So how does it work? Very simply, you take the T cells from the patient. You will take the cells into your kitchen. In the kitchen, you will genetically manipulate these T cells to attack specifically the tumor. Still in the kitchen, you will put some buharat in order to expand the number of T cells, liberating billions of active T cells ready to kill the tumor. Then brief chemodebulking, followed by the infusion of the very active T cells. So now the CARs can crush the tumor, in fact, just like this. Okay? Right. Bottom line and conclusions. Of course, when I say always bottom line, this is my favorite. In conclusion, significant improvement had been achieved in the fight against all types of cancers. However, the blood wins against the solid tumors. We did not win the whole battle yet, but definitely we did improve our approach. For our, whether, as I told you before, whether we accept or not, it's a matter of cytogenetics and molecular genetics. And excuse me if I say that if you manage hematologic malignancies without cytogenetics, this is a malpractice. So the present is the targeted therapy, while the future, as we can realize now, cellular therapy and genetic engineering. And in hematologic malignancies, many nightmares are now becoming, okay, sweet dreams. But unfortunately, ladies and gentlemen, one nightmare can never change. حد عنده أي اقتراح؟ إيه النايتمير اللي استحالة يتشينج in our lives؟ إيه؟ إن شاء الله هنخلص منه. بس في نايتمير عندنا كلنا في العالم، 8 مليار. استحالة إن هو يتغير. Aging. تمام؟ Aging. Except في يعني شخصية مش بقر والله، بس بسم الله ما شاء الله عليه يعني. كويس؟ يعني ما بيفرقش قوي الايدجنج معاه الحمد لله يعني. المصيبة بقى انه he is of my age. I'm so happy بالحكاية دي. Well, thank you very much.